Hi, my name is Subashni Maharaj. I am a neonatal pediatrician from Adelaide Pediatrics, Ashford, and it is with absolute pleasure that I have been invited by the fabulous OTFC to share all of my thoughts, experience, knowledge, and expertise on neonatal and developmental care.
Hello and welcome to the Integration Station. I'm your host Michael, a child and adolescent occupational therapist, and with me today is a special guest, Subashni Maharaj. Subashni is a paediatrician with close to 20 years of experience. Having completed her Pediatric Fellowship in 2010 in South Africa and Neonatal Fellowship in 2019, she moved to Australia with her family in 2022. Subashni's goal is to equip families through every stage of their children's lives and to empower and ensure that they have the skills and confidence to work through the challenges that life presents. In this conversation, Subashni brings a wealth of experience and covers a range of topics from neonatal care to child development and supporting families as they journey through challenges in their life. One thing I took away from it was the perspective of the change in an environment when a newborn is brought into this world. From the dark, warm comfort of a mother's womb, this child springs to life in an instant, and that first hour of life is so important. Subashni covers all this and more, and I hope you enjoy the conversation as much as I did. But can maybe I start with, as a paediatrician in your field, so say someone has a child, a new child that is born, and they are looking to consult a paediatrician. What does that process look like, and how do we get to see someone like yourself?
I think if I target first what it would be expected as part of a newborn journey, with being a neonatal pediatrician, I am very involved with the patient care right from the onset. So usually if it is a high risk pregnancy, I would have the allocated obstetrician who would inform me about the family, whether it is a maternal risk factor or a neonatal risk factor. And I actually offer pre-counseling to the families, so pre-delivery counseling, maybe around between the 34 week period. And that entails just having a feel for the family dynamics. What are the challenges that the parents feel they may have for the rest of the journey? It's obviously just being pregnant first time parents is, I think,
a lot.
Yeah. And
absolutely.
if there's an added stress of a medical condition or a risk factor to the mum or the process of delivery and the baby, that's just an added stress in itself. So whenever I have these families come to me, I need to validate what they're going to. I am very transparent about what some of their concerns would be. And from a medical perspective, we always follow evidence-based medicine and guidelines, and every family, every pregnancy, every risk factor is unique to that particular family. But I think the counseling session is based upon what are the risk factors and what are the known statistics and transparency about the course. It gives me a chance to introduce myself face-to-face, be with the family, have or answer all of the questions to the best of my ability, but most often than not, alleviate some of the anxiety that both the mom and dad are feeling at that moment in time. It makes the birthing process a bit easier, in inverted commas, because I would have met the family prior to meeting them for the first time in labor ward or at a cesarean section. And we have known what conversations we have had preceding the delivery. If I didn't meet the family at an earlier stage during the gestational period, then my first interaction would actually be at the delivery. And I think I love creating a very relaxed and also jovial atmosphere. Like, this is such a joyous occasion, and it's very easy to sort of get drawn into feeling very anxious about having a baby and obviously worrying about your own health as a mom, the dad worrying about the mom and the baby, and then worrying about the baby itself, right? So I think us as pediatricians, our job is, we provide the neonatal care, help with that golden hour of life that our newborns experience, but just making that entire process a memorable one in a very positive way. And then once the baby is born, I think the golden hour of life is probably a discussion all on its own, but I think everybody underestimates the actual effect that life has on a newborn. Like I always tell the parents, like, can you ever imagine yourself or put yourself in your baby's situation? Like, you're literally leaving the dark womb that was quiet, you're swimming around in the amniotic fluid, and then you're in this cold, bright, loud environment. We are all excited to see you, so there's lots of camera clicking and oohs and ahs and screaming. And when we don't know the sex of the baby, it is such a fun experience because then it's such a big reveal, right? But still very overwhelming for the baby, who now for the first time takes their first breath of oxygen, and we don't realize that they're breathing in the amniotic fluid in the womb, and having all these physiological changes taking place at like a cellular level. And so us as pediatricians need to be aware of that and help with a very smooth transition from like a neonatal onto like an infant care situation, but at the same time being there to support a mom who is very anxious. A lot is expected of her. And I think that's where we come in past that stage of delivery, but just to be there for the next 3 to 4 days when they are in hospital and help them through that process of sleep, feeding, how to actually support the needs of your baby, reading the cues of the baby. I have a lot of families that tell me, we've done this 2 or 3 times before, but it still feels like the first time with every pregnancy. And it would, because every baby is unique, and some conditions or situations that you might find yourself with your third baby is nothing like what the first and second pregnancy was all about. So it is a journey, and I think our job is to sort of make that journey a little bit more easier for the family. And what I love is my postnatal ward rounds. Like, I start the day with the postnatal ward rounds, every day seeing the babies. By the 48, 72 hour mark, we do like a proper baby check that has to be documented in the health record book. If there were any risk factors, it's documented. If there were any challenges during that period, it has to be documented in that book. But I think the challenges mainly is to get on top of sleep and feeding and lactation. Lactation is actually a very big deal, I think. I work at a hospital whereby we have a lactation consultant on site. So it's very easy to link a mom up very quickly with a lactation consultant in order for us to try to alleviate some of the concerns that she may have. But when we target these issues very early on, it makes that next 6 weeks process until I see them again an easier process. Because if there was a tongue tie that I noticed or the nurses noticed, it would be sorted out if the parents wanted to be sorted out to make the feeding easier. Or if there were challenges with breastfeeding, or just, I think, assisting maternal care in the situation would be important. So I think that journey with supporting family as a pediatrician is right from inception going on. And the importance of a pediatrician is then when they present to us at any stage of development as an infant is basically determining, are there any risk factors with growth and development? And at an older stage, going through the milestones and determining if there's any risk factors from a developmental perspective, and then early targeting of any delays or challenges with regards to development. You may or may not have a child that might present with a general medical condition, like maybe first onset seizures or features of asthma or allergies, food intolerances. And so when you present to a pediatrician, you may just, as a parent, have some concerns, but not really know what's going on with my child. Like, there's something going on, I just don't know what it is. And that's you literally, they're like, something's going on in my child. When I feed her, she cries, or when I try to speak to him, he's not responding. And our job is like, it's going to be okay.
Yes,
We are here to sort of go through every single tick box and see what is going on. And then I think with me, I'm very passionate about early intervention. So if there are any concerns, targeting what the concerns are, and then basically linking the families up with a multidisciplinary team that will be able to assist in that perspective. But I think the role generally as a pediatrician is just making sure and validating what parents are feeling empowering families to take heed of where the challenges are, but at the same time supporting the child with their strengths, and then just assisting the child throughout the journey and being an advocate for the child throughout their journey. I think when I have my older patients coming through to my clinic, I always ask them if they are aware of why they're here to see me.
I do the same in my assessments as well.
Absolutely. It's like, do you know why you're here? Do you know why mum and dad brought you across?
Normally my answer is because mum and dad said I had to come, or a parent said I had to come, but
possibly.
when they're younger.
And my kids that actually have like a background of possible ADHD was like, I forgot. I can't remember. But that gives me a level of how to then, like in my mind, pan out that session. Like, because if the child is just unaware, and if it's like major issues, how to sort of target that, but in a very non-confrontational way to a child who's at that age where they're very understanding about what is actually going on. And I always tell them, this is going to be like one of those very weird consults whereby mom and dad are talking about you in front of you. And it's going to be very challenging to hear some of the things, but they need to be honest about what you're going through, because my job is to figure out how to help you. And if there's no transparency about the problems, then it's going to be very challenging for me to also know at what stage of the journey they're at, and then what my recommendations would be. But I think my approach is always holistic, like just taking into consideration what each parent has, I think, experienced with a child, especially if they are from shared household. I think the experiences and behaviors of the children always differ, and it can be very complicated if each parent has a very different view on what the actual problem at hand is, and then supporting the child at the same time, and then realizing, well, that's a family unit, so there's other kids that are in the mix. So yes, you've got one child that maybe has special needs and needs a lot of support, but at the same time you don't want to ignore the other children and not support them in the same capacity. So it's very much a holistic management of a family unit, but just validating what they're telling me and empowering families just to sort of like take the front seat and driving their child's healthcare.
Yeah, wow.
Yeah.
A lot to take in. I think a few things I took from that first thing was I remember when my son was born, was that realization of just coming out of this dark space into this light, and just how alert they are. But I've never thought about it in that perspective of that almost being in their shoes about what it would be like to come out into a world where it's so novel. Everything you experience is new. Like nothing that you've been in before is like this. So you're right. It's a lot to take. It's a lot to take on.
It's a lot to take on, and I think then it's also, babies need to figure out that they need to work for their food.
So all those things.
All of those things. Like now, it's like everything is new. Now they need to breathe, suck, and swallow. And I always tell the parents that, have you ever just thought about the fact that now they are the ones that would have to do the work? They need to breathe, suck, swallow, take in the nutrition, understand what's going on. So it's a lot for the baby. You know, when you sort of like think about that period, I think a lot of people, as you said, like just don't understand just the sensory overload that a newborn experiences. And that's where that golden hour of life comes in, because we need to support every aspect of that transition, because that is when there's continuous maturation of the neuronal pathways of like every single organ. And you don't want any, I think, challenges that can or may come across that's going to regress some of that development.
So you mentioned the golden hour of life a couple of times. For those who might not be familiar with what that means, can you maybe explain a bit more?
Yeah, sure. So it's basically that second after the baby is born until that hour.
Yes.
And it's very much them taking in their first breath of life, and there's very different circulatory pressures that you sort of may not be aware of. Like, so when the baby is in utero, they are actually breathing are taking in the amniotic fluid. So their lungs are actually filled with fluid. So there's a difference between what the pressure is in your lungs, which we call the pulmonary pressure, and what the pressure is within your heart. But when you take that first breath of air, the pressures all have to change, as in that fluid needs to then become absorbed into the system. Your lungs need to fill with air. Your heart now needs to pump and take responsibility more for the circulation. In saying that, there's certain factors that we have to make sure are within our normal limits and ranges, as in the baby takes a while to transition. So you would notice they would have purple hands and feet, a little bit bluish discoloration of the lips. And as that oxygenation improves, by that 10 or 15 minute mark, you've got a nice pink baby that you see on the Instagram photos.
Yes.
And you also always envisioned your baby looking like, right?
Yep.
So that's important, oxygenation, because you want that oxygenation to be at the level that it should be at, so that the entire cellular level and circulation works expectedly, right? At the same time, you want the heart to be beating at a rate to maintain that circulation. We would check the blood sugar levels of the baby just to make sure that if there's any concerns with feeding, and if that is then a complication to the child developing hypoglycemia, which is low sugar levels, that in itself will have complications. Acutely and chronically, like persistent low blood sugar levels. So we target that. You also just want to make sure that the baby is able to regulate their own temperature, and that's why we would say, you've always noticed a baby with like a little beanie and socks. It's like we need to keep the head and the feet warm and help with what we call thermal regulation. So a high temperature and a low temperature affects metabolism of the cells. So those are just a few things that we need to always keep a watch on. So when the nurses come in every 4 hours to check vitals and the parents are being disturbed, we just have to explain to the parents, well, this is why we're doing it. This is the importance of it. So we always try to get those target values in that first hour of life. So that transition postnatally is what we want it to be. And every situation is different. It's a completely different discussion if we have a child or baby that is known to have had a cardiac lesion. So the way in which you manage those complex babies is different. But this discussion I'm having with you is just a baby with no risk factors. And then that would be important for us to do. So there's a reason why everything is done in the hospital. There's a reason why we come and check blood sugar levels. We want to make sure the oxygenation is fine. So it's sort of just making sure we support the baby right from the onset to prevent any complications that may occur if we don't get it right at the beginning.
And I guess that's what you're saying also about the importance of that, that interdisciplinary approach. There are other allied health services, and you talked about lactation consultant and feeding and sleep and supports in the first, few days can really help not only the baby, but also the family when they leave the hospital. And I still remember the first time I took my son home in the car. I'm like, I'm just walking out with him. Like, is this it? I'm like, what do I do? Like, I'm driving really slowly home, and it is that sense of now it's on you. So when you're able to provide as much advice, and what I'm hearing from you is you very much have that holistic approach. As a paediatrician, you take it, not that you wouldn't take it seriously, but you take that so seriously that it's not just about the care whilst I'm with you, it's the care about how I can empower and support you to then be the best versions of parents that you can be.
Absolutely, 100%. And I think those are the memories you go home with, right? Those are the memories of like what it was, who was there to support you, who made the journey easy for you. So I will have parents coming and telling me, I still remember what you wore the day. Like there's just like little things that they would remember that they take home with them. And like, I think bringing that support, holistic support, like I have actually employed GPs into my practice, pediatric GPs that actually have passion towards infant care as well as behavioural, because that's basically like my 2 dimensions in my clinic. But I offer like the families a 2-week check with the GPs. It's this real-time consultation that the families are offered in that particular perspective, as in like the pediatrician came into the room, saw the baby, gave advice, and then when I followed that baby up at 6 weeks, it's like, oh, guess what? That rash has disappeared, or that lump wasn't an issue. So I think with me, there's this continuation of care, which I love providing. The fact that I'm discharging you on day 4, day 5 of life, you're coming in to see a GP. I know exactly the type of support I am lending to them, and that maybe that problem that was, or concern rather, that was present at the 2-week stage, if it's not adequately, I think, challenged and sorted out in a way at that 2-week mark, can progress to when they come and see me at the 6 weeks. And it may just be like a bigger problem than it actually should be. So I find just targeting these situations early on prior to that 6-week check is important. And what's really important is also just telling the families and giving them this sense of awareness that those first 6 weeks are really challenging with sleep and with feeding, and a few may or may not have some reflux issues and some cow's milk protein intolerance features. So there's a lot that goes on, and I find that sometimes if you just make families aware that the journey is not going to be easy, they sort of prepare themselves for what may come along and then find that they're able to handle it. So I think education for me is always big. Just educating, empowering families, and just being very transparent about what the journey is going to be like. So families can actually make themselves aware of what to expect, and it makes the process a bit easier. So yes, my ward rounds are never a fast ward round because there's a lot of counseling that I actually do during my baby rounds because I want the families to feel more secure in their own abilities when they actually walk out of the hospital.
And absolutely, when you think about the importance of bedside manner, and you said you remember, like families will remember maybe if it's a nurse or a paediatrician or someone that has spent time with them, and the relationship is almost more important at times than the care. I mean, I say that in all respect, but at the same time, if you can be a caring and validating, supportive person, sometimes people remember that more than, say, the advice that you gave, for example. So, very, very important. I did want to, so you talked about the experience of, say, a young person that's brought into this world where it's, things are as expected. What about for like a neurodivergent young person, or say which obviously you wouldn't find out until later, but say someone that does present with more medical challenges or other health concerns? How does that differ in terms of your approach, or how would that differ in terms of how you might explain or consult families in that situation? Yeah,
good question. So I actually would never have ideally been the first port of call in that situation. There would have been like a CAFS nurse or a GP or any other multi-allied team or multidisciplinary team that would have picked up some of those red flags. So when the referral actually comes from the GP to myself, I just have an idea of what has occurred and what the underlying concerns are. Sometimes, yes, there is probably a lot of the concerns that would have been picked up at that point, but I always prepare the families for what further on I would actually come up with and determine a further concerns for the families. I actually go through the referral, know exactly what to expect from that family. In that period that they are awaiting to see me, I would send a letter back to the GP to say, have we done an eye test? Have we done a hearing test? Has this child had a nutritional screen done to exclude a micronutrient deficiency? Because maybe that is some of the behavioural concerns, developmental concerns. If there's a background of possible autism, have they already been linked with a psychologist, OT, speech therapist, physiotherapist, behavioural social worker? And if so, can I have all of those reports and school reports? So if it is a child that's attending a kindy or even a daycare or a school-going child, I want reports from the teachers. You have to have a very holistic approach as to where is this child? when they come to see me. And the reason why is because neurodivergency, when we talk about neurodivergency, it's just this umbrella term that we use to describe any child that just views the world differently. And I know it's described as a disability, but in my opinion, it's an ability to view life differently, not in an incorrect way, just in a different way from the rest of society, right? And under that umbrella term, we've got autism, ADHD, mood, anxiety disorders, learning disorders, sensory processing disorders. So just so many conditions that sometimes all integrate into one bubble.
Yeah.
And it's very challenging sometimes for the parents to understand, what is my primary concern? What has led to the other symptom? And I often get this question, what's the first problem?
Yes.
And I'm like, actually, it's all a problem, right? I've got a problem list, and yes, I've numbered it. And I will tell them, well, the problem is, if you have to really sit back and think about your child, what worries you most about your child? Like when you wake up in the morning, and if you think about your child, you're getting your child ready for school or for the day, what goes through your mind? Is it the fact that they've got inattentive features, or they're hyperactive or impulsive? Or is it the fact that your child is so anxious that they can't get out of bed to even go to school, right? And I am there to target your number one problem. Yes. And then we'll go through problem number 2, 3, 4, and 5. But for me to sort of get those reports from multiple disciplinary team members, school included, I just already have an idea about the child that's coming to my clinic. And I already know what that session is going to be like and how to target issues. So I do take a history, like a proper history, starting from birth, past medical, developmental. Is a child on any chronic medication? Has any known chronic illnesses? Because chronic illnesses can impact them attending school, and that can then lead to academic challenges. And maybe the primary concern is academic challenges. So we have to backtrack as what's going on and what preceded that, and whether or not, and go into detail with development. I think that just gives me like red flags with neurodivergency, if that's the concern. Like the concern would be at 2.5, this is what he would say from a speech communication perspective, and then parents notice regression.
Sure.
So with regression in speech and communication, it's going to affect every other domain. So every development is going to be delayed or of a concern, because you have a child that cannot find the vocabulary to express themselves, they're not understanding what's being told to them. So that kind of like links up to everything else that's going on with the family. But targeting every aspect of the child from head to toe is important. Targeting diet, sleep, screen time, what is going on with learning, what are the support systems for learning. And again, if it's a behavioral or a developmental concern, if there's a shared household, are we actually seeing that in both households? So I think it's very much a disciplinary approach to the kids. If there's a general medical condition, I would have literally sort that out, and at the same help to sort out like from a developmental perspective. And you know, there's some families that already have probably Googled what is neurodivergency, what is autism. They may have been linked up with a speech therapist, occupational therapist that have already brought up the topic. And regardless if somebody had mentioned those features to them, there's always a sense of denial. There's always a sense of, this is not how I envisioned life to be. I've never had that experience in the other 2 children, so this is all new to me. Or like this child like smashed his milestones or smashed her milestones for like 2.5 years, and now what is going on? So it's very much a sense of like, who is this child? What is going on? Like their situation is very different from what they thought life would be. So there's a lot of counseling that happens during my consultation, especially if I could see that there is a sense of denial in a family that has a child that has severe developmental concerns with a child, or is presenting at a severe level of ASD, like a level 3 ASD, and we have to start that process as in we need to get the diagnosis. And I always give the families time. I said, you need time to process what is going on, because unless you process and accept, you won't be able to help your child. So you need to just take that back with you, like read upon it. There's support groups that are available. The teachers can link you up with other families who are experiencing the same challenges that you are. But at that consultation, I basically would just take the history, and then from the history and going through the criteria of autism, I would have an idea as to whether or not the child may or may not be. And the reason why I say that is, I mean, yes, the history may be in keeping, but then we have to use a proper assessment tool, like an ADOS tool, for example, or a CARS tool, to help us make that diagnosis and clinch it and confirm the diagnosis. So I have a team that I will refer my families to. But when I pick up those traits and it actually to me is looking like this could be like autism, definitely, I start that process of educating the families a lot about neurodivergency. And I think for me, it's just focus on the abilities that your child has. Yes, there's a few things that they are finding challenging. Let's not see it as a problem. Let's see it as it's developing, you know, and that's where we need to help them. Like maybe the communication skills is not where it's meant to be, but it's developing. And that's why the speech therapist is coming in. Maybe they have sensory processing disorder traits that is contributing to the emotional dysregulation. So like interoceptive sensory processing traits, we underestimate that effect of, you know, like mood swings going from like 0 to 100 in a split second, but like stepping back and putting yourself in your child's shoes, especially if there's an expressive language delay, they can't tell you what they're going through. And I always tell the parents that if you're going to be sucked into that drama, you're going to feed off each other's unhappiness and meltdowns. And it's easier said than done, because like the mom is like, I just can't handle it. The dad is like, I can't just do this. It's too much. I'm like, then just walk away. Walk away. Try to offer a snack. Give them something to drink. Do they want to take a nap? But come back to them when you are more regulated as a parent. Otherwise, you're never going to be able to figure out how to help your child. And then you just feed off each other with arguing, and then you never find a solution to the problem. So it's very much like validating what the family is going through, but giving the family advice to take a step back and help themselves first before you're able to help your child. And that's kind of the message I love to give families, is always take care of yourself. Yes, you've got a child who is neurodivergent or has special needs, but if you do not take care of yourself in the process, you don't have capacity to take care of your child. And that's really important.
And I think that's a common theme that we often talk about, you know, in our assessments when we're working with families is that co-regulation. If you are struggling to regulate your own emotions, then two things. One, you can't be there for your child, but also you're modelling a way of managing a situation. And it sometimes might not be your intent, but it can come across as, I'm frustrated, therefore when something's not working out, that's how you respond. So
absolutely,
very important, you're right, about managing this that co-regulation. When you were talking before about those milestones, I know there's, I guess from more of a neuroaffirming lens, that developmental milestones are a guide, but everybody, you know, matures in their own stages, but more of a medical model would say that milestones have to meet these milestones. I guess what I'm hearing from you is that you're trying to take a bit of both. You're trying to take an approach from here and understand that we have a neurodivergent young person whose milestones, you know, they're at their level that they need to be, but compared to others, this is what it looks like. How do you treat milestones in your practice then?
The milestones are there for a purpose, and yes, those milestones are based on research on neurotypical children, right? So we've got like those, like a little age range as to when a child should be developing a few of these milestones. So we've got like your gross motor skill, big muscle movements. That's what I explained to parents. Fine motor skills, small muscle movements, self-care skills, speech communication. Speech will be vocabulary. How many words do you use? How are you pronouncing the words? Are you putting into like 1-word, 2-word sentences? And then expressive language skills. How are you now taking those words, your pronunciation, your sentences, and expressing yourself, right? So verbal expression. And then just that concept of understanding what another person is saying to you as well. And then their social, emotional, and cognitive function, right? So when we talk about developmental domains, that's basically like what we're targeting, and the milestone range is based on the neurotypical children. It is there for us health professionals to know that yes, we are evaluating a child who is neurodivergent and is now developing at their own pace, and we as a practitioner and parents have to be flexible around that process.
You're changing the goalposts there to go, well, now your milestones are here, and we're, working
100%.
from there.
It's like, just be flexible in how you're seeing it, but it gives us an idea of where are you at this moment in time. Like, we know this is where you're supposed to be, but you're currently here. And so we are starting with you from this level, giving you all the supports you need. Whether you reach this level, at whatever stage in your development, fantastic. Like, if you're able to then communicate at a particular stage in your life, which is within that range we expected, great. But if you're not, there's other ways to sort of communicate. I mean, that's why we've got our visual cue cards. That's why we've got our social stories. Like, think out of the box with how you would want to communicate with your child. There's so many non-verbal ways to communicate. Like, we can have a conversation with not speaking to each other, but just using our facial expression and our hand.
The majority of communication is nonverbal.
Absolutely, right. So there's so many ways for us to target that nonverbal way of communicating. I think it's just this learned response. Communication is the way we are learned as human beings to speak and voice our opinion. But when it comes to a neurodivergent child, all of that goes away. Let's start off from scratch. Let's all think of an out-of-the-box way to communicate with our child that is understanding to them, and they are able to express themselves. If I have to put myself in a position of an autistic child, level 3, who is mute, imagine what the world looks like. You just have to take a step back and just think of how important communication is. And if you don't have that, how challenging life can be. And that in itself will lead to every other challenge that a child can have. So if a child doesn't understand what's being said or can't communicate, when they go to therapy, they will not understand what the therapist expects them to do, whether it's an occupational therapist or a physiotherapist or a dietitian, because just can't comprehend what is expected. So that one developmental domain can actually lead to delays in others. But it's very much like there is a delay, and this is where you're at, and early intervention is linking everybody up in the process and then assisting that particular domain to improve, but at the same time, you're targeting the child holistically, so you're getting on top of everything. So if you have a child who is autistic and is restrictive in their diet, so I call them my beige bandits, which I have quite a few on, right? And it's then thinking, so who's going to help in this situation? So the referral will go to my dietitian to say, look, this is our little beige bandit. We need to improve the diet plan. The family needs assistance with that. Like, how can we then introduce textures and colors into the child's diet? But then I would need help from the occupational therapist who comes in and goes, these are textures you want to do. Let's go crunchy. We don't always have to go smooth. And the dietitian would say, why don't we just puree these vegetables that they don't want to eat at the moment and just mix it with the mashed potato that they want to eat, or like put it in the crackers as a dip that they prepare to take. So kind of like just take what the child is doing at this moment in time and not put too much of pressure on what's going on, but then link them up with a team that can give more advice. Because if you ask me for the diet plan, I'm like, okay, I'm not sure. Because that's not my specialty, right? Unless I kind of have this interest and I read up on it. All I can say is, let's puree, let's make it fun shapes, let's make eating fun. Why don't the child just sit with families, and then, children like to kind of copy what parents are doing and siblings are doing. So if you're taking an apple and eating a banana, the child might do the same thing. Let's play with texture. So let's just put the mashed potato and let them like draw little shapes. Like, like if you ask me, that is what I'm going to say. But like linking them up with the dietitian would be taking it a step further. And these are the food groups. This is what you can target, and this is what you can bring into the child's world, right? And then the OT, playing around with textures and helping with that oral texture. Everything's very sensory based with the neurodivergent children. So targeting that, and then bringing my speech therapist to do a feeding assessment, but also just give me an idea of what like the oral and feeding development is of the child, and then having my GP there and making sure we are all consistently linked with each other and getting the plans together as we should. And I've got my little network team that's going to be of assistance. And what makes a difference is that my team can pick things up and go, you know what, we've just realized and we've seen him or her. This is what the other concern is. So let's take that a bit further and let's do stuff. So like, it's kind of like really knowing how to target every aspect of where the challenges are. And then that brings me to psychologists who are so important in this process, just really assisting with behavior modification and coping skills for the families. That's very important. I mean, we come up with all of these recommendations, but coming up with the recommendations on paper and getting it done and trying to link up your child with who they need to go to, that's a long waiting list.
Yeah. And obviously you've talked a lot about sort of, I guess I would consider almost Western medical approaches, but at the same time, you're right. I think in a lot of cases, I've had a lot of people have great success with equine therapy and other music therapy, and even though music therapy is a registered practice and is well regulated, I mean, people think of therapeutic supports as speech, OT, physiotherapy, dietetics, those sort of things. But obviously, for when we're talking about neurodivergent populations, there's a whole range of other services that it's one of those situations where if it works for one person, it might be effective for that person, but it might be exactly what they need. And I think in our scope, I know we're purely OTs in what we do here, but we've always found that, and our national director Dino, I think back in talking about paediatricians as like your annual checkup. He always says, go and see the pediatrician every year. It's like a checkup, like you'd service a car every year. Go and service a child every year with the pediatrician. And I don't know why, but that's stuck with me. And I don't know what your thoughts are on that, whether or not that's something that you would recommend for all families to have a consultation with a pediatrician every year to see how things are going generally, or is that maybe something that's not necessarily required?
I think it just depends on what the concern is about the child. Every child is unique, and I feel like if your child is tracking well in all aspects, as in you as a parent, you're actually just very confident in how your child is tracking, then that's fantastic. I think, you could even link in with a pediatric GP, because then they would actually just be learned enough and have that experience. And if there are red flags, then they would refer that particular child to us. If it makes a parent feel comfortable enough in their own capacity and how they're supporting the child, then yes, having an annual checkup is something that can be done. But it's a situation where you then are linking up with a pediatrician that may or may not have capacity to do that, because there's such a long waiting list to see a pediatrician. However, once you're already part of our clientele, you would get that services. If it's a high risk, it'll be a 4-monthly check, otherwise a 6-monthly check or a yearly check. So I think most often than not, most children are linked up with pediatricians at an early age and stage in their life, and then that's how you sort of have those annual checkups, which I agree, it makes a huge difference, because some things, like sometimes I would get a child that the parent will hear about a concern for the first time during my consultation, and they would turn around and go, you have never mentioned that. And now you're coming here to see Subashni. And it's like a review appointment, but this is like a whole problem on its own, right? So I think sometimes children also feel comfortable to speak to somebody who's not their parent. So yes, I do pick up a lot, actually, now that I think about it, a lot of like situations whereby parents were not aware of certain situations, and then all of a sudden at that appointment we pick up a few things. But look, as long as we picked it up and we can target it and we can do something about it. So yes, I mean, if in capacity and if it's available and feasible, then annual follow-ups would be important.
Yeah. And obviously you're talking about yourself in the private sector, in the private space, but obviously there's a range of paediatricians that work in the public space as well. But what I do know is that the wait list for private is very long. The wait list for public is even longer. So it's certainly, if a parent does have concerns and they do feel, you mentioned before about that, that referral pathway or understanding, if they do see some red flags, then what is that referral pathway to see a paediatrician such as yourself, whether it's through the private system or the public system, for families out there? What's their first step to then get referred to a paediatrician?
The first step would be the GP.
Yep.
So we would accept referrals from the GP, because the GP referral will last for about a year with us, which means for the next year, we can follow the family up as many times as we need to using that referral form. And sometimes if there are concerns that was picked up by a psychologist or an occupational therapist, then the parent always goes to the GP.
Yep.
And the referral letter will specifically be the OT noted the sensory features or possible features of autism, etc. So the first line is always going to the GP, getting the referral, having the referral come to us. Sometimes, like for example, I take care of families. So it's like one sibling comes and then subsequently the second and third and fourth would come. Which can happen. So it's always like a named referral that will come through, and it's like literally having families come to me. So, I would have like a morning, and the morning would just be family so-and-so. And like all the siblings. If it's a new family, they all come in. If it's like a review appointment, but...
Yeah, and I think that's, we have similar situations here where, it comes down to, as you said, if you provide a service that families feel is not just a good service, but a trustworthy service, and your interactions are really positive and they feel as though they can develop a good relationship, then of course the whole family is going to come and see yourself, and that's what you want, right? You want that trust to develop, because sometimes a big change, and there's a big, if it's a neurodivergent young person, those stages of grief can be quite long, and so if you're the right person, you can guide and counsel them through that, then they're going to keep coming back to you and listen to your advice because you develop that trusting relationship.
Yes, absolutely. And I think also, like, I've had many situations whereby I would then go through the traits of autism or ADHD and mood anxiety, and the parents would look at each other and it's like, no, he doesn't do it, but his sister at home. She's got all of that. And so that's kind of how the conversation would go around, where the referral will be from one child, but that consultation with me for that child then prompts them to further evaluate what is going on with the sibling. And then I think that's how the families come. Or I have a lot of families referring other families and peers from school or friends. And I would sometimes have a waiting room with friends. They all know each other from school. And they sometimes, if they're traveling away from Adelaide, they travel in convoy,
but that's
which
amazing.
I love. And I'm like, that's so
fantastic.
good, because then the kids are in a good mood and they're with their friends. But like in that consultation with that family, a lot of times that is how I have the siblings coming to me. The family's just realizing that, nothing is going on with him, but this is what's going on with my other child.
Look, I feel like we could talk for hours about all the different situation scenarios. You talked about some food stuff, and we didn't go into that too much, but there's a lot there. But I feel like we've covered a lot to do with that neonatal care, to what you might see with our neurodivergent population, and again, we didn't talk about what happens when they do age out of that the paediatrician into the adult space, but that's probably something for another time. But I hope that a lot of the families who are listening to this do get a really rich insight into not just what it's like to be a paediatrician, but what service you provide, and your clinic in particular, and how holistic it is, and how much you do care for those families.
Absolutely.
And the journey being so divergent can be a lot more stable. That ship can be less rocky with the right team in tow. So,
yes, absolutely.
So thank you very much for sharing your
Thank you.
your
Thank you for
expertise.
having me. Thank you for giving me this platform to educate families. And as I mentioned, I love teaching. I love educating, and I love empowering families to take the front seat of their child's journey. Because if there's anybody that can make a difference in a child's life, it's not a multi-allied team member or a pediatrician, it's actually the parent.